Hi friends, I hope you have seen the last video of our secondary amenorrhea. If you have not seen, please close this video and watch, because without knowing what are the diseases, if you come up here, there is no point. So go watch that, then come here. Okay, today we'll discuss the workup. Okay, workup of our secondary amenorrhea patient. Okay, workup of secondary amenorrhea. A basic approach of history, examination, investigations, treatment. We'll have this template and we'll extrapolate. Nothing to remember. Okay. See, last class. One more thing which I need to say is, see, after examination, I told you will come up to something called as provisional diagnosis. Before that, for God's sake, for heaven's sake, please think about physiological causes also. Why do you think I'm talking about physiological cause here? Yes. Darling, say me, what is the most common cause of secondary amenorrhea? Anyone? I've already given clue. I told it's physiological cause. This pregnancy is the most common cause. And next is lactation. But according to some definitions, they say excluding pregnancy or excluding lactation. So make sure you are, properly guarded. Write definition properly, or while explaining you say this is the most common cause physiologically. Don't say that is pathological. If it was pathological, none of us would have been born. So that is something which you should know: pregnancy and lactation. Okay. So I told one more concept today, that is you should think something about physiology. See, you at the end you will treat patient, not books. Correct? No. So normal things which happens is mostly physiological. So in workup, I will say you, if you don't do UPT, and if you started on any OCPs, or if you started on any teratogenic drugs, gone. You have to go to jail. You understood the importance of doing UPT. See, if any woman in your OPD comes with any of the problems, I don't know the cost, but do UPT. I mean, that is so important. Medically, very, very, very important. Otherwise, you will kill not only one life, you will kill that life also. You will put women's life in danger, and you will go to jail. I mean, you understood no importance. So, yeah, after all this, now we'll discuss the workup. I know I might have talked much, but to save your place, this is important. So now you know the definition. I'm not talking about definition. For that, you have to watch that last video. Correct, no? What do you think? I don't have any other. Yeah, secondary amenorrhea. You have a patient of secondary amenorrhea. Think about physiological cause. UPT should be done, irrespective of what she is. Okay. And then rule out pregnancy and all those things. Then basic panels here includes even thyroid, prolactin. Okay. So that you know what, if this is abnormal, treat that cause. Now you did this much things, everything is normal. Yes. Now I want to say why that anite physiopatho approach is very, very important in your life. See, always think locally, act locally. See, why do you think I'm saying? Sometimes this progesterone is something which stabilizes the uterus, I mean endometrium, right? So we think this secondary amenorrhea is something to do with stabilization of your uterus. So what we do is something called as progesterone challenge test. Okay, progesterone challenge test. Yeah, for 5 to 6 days you will give progesterone, then you will withdraw it suddenly. So I told also types of bleeding. Here you will have progesterone withdrawal bleeding. So if you have bleeding, that is withdrawal bleeding, if it's present, implies what? That axis was intact. Correct, no? So you will do the LH and FSH ratio. That basic biochemical panel, you can include there itself. LH, FSH and androgens you do. You will see LH will be high, almost constant. FSH might be normal, but that LH versus LH by FSH ratio will be more than 3. Then you have to do a pelvic ultrasound. You'll see, you might get to see a PCOS case, because this is common. Okay. Now other case, it is not absent. So imagine there is a gross problem. So locally, very locally we did. Now we will see locally. That is overall uterus. So that means you have to think about that estrogen is not there. Okay. So there is no expression of progesterone. So now you do something called as estrogen plus progesterone challenge test. Okay. Now if she bleeds, again you have to do a FSH and LH ratio. See that's why if you include this here itself, I think it's good. I was thinking, okay, let us include here itself. Some 200-300 rupees cost, I guess, I'm not sure. Okay, so you did the hormonal panel. You see FSH is low. Then yeah, if estrogen is low, estrogen is low, then FSH is high. She is a case of, her age is 40. What do you think I'm talking about? Yes, you already told me, it's pure primary ovarian insufficiency. Okay. Now she doesn't bleed. That means what, man? That means there's something which is obstructing, or something which is very higher strata. Correct, no? So if she doesn't bleed, again you have to do an FSH and LH thing, no? So if she is not bleeding, that means you have to think something related to blockage. Most likely Asher. Okay. And also when you this is one thing. So this is the end point. But again, for that upper strata approach, this FSH and LH is something which guides us. So if estrogen is low, it's POI. But what if estrogen is normal and it's in the normal low range? See, low FSH, low LH. Okay. Who will produce these things? Hypothalamus. Sorry, pituitary. So something to do with pituitary. So what do? I told you in last video, GnRH challenge test. Plus, if patient can afford, do an MRI. Here only you can say, but you can see what are the problems. So if GnRH challenge test is positive, that means what? Hypothalamus was intact. That means hypothalamus is, there was something to do with hypothalamus. If it's not, that means she doesn't bleed. There's something to do with pituitary. So if you do an MRI here, can either have adenoma, Sheehan's, prolactin. So you must know how to differentiate each one of it in MRI. Got it? So here again, you do something called as GnRH challenge test. So it can be either normal or exaggerated or no response. So what does normal means? That means functioning of pituitary is normal here. That means, see, you are given GnRH, it is producing LHFSS. That means what? Pituitary is normal. Exaggerated means what? Something related to hypothalamus, mostly calming. You gave us stimulus, it started producing what? But what do you think is no response? No response means, see, GnRH is there, you are giving it exogenously, but it is not producing LHFSH. Who produces LHFSH? Pituitary. That is something to do with pituitary dysfunction. Then you order an MRI. So now you know what is the use of GnRH challenge test. If it's normal, then pituitary is normal. If it's not normal, then pituitary is abnormal. If it's exaggerated, most likely hypothalamus. So this is the overall gist. So I discuss the basic things now. The basic workup. Okay. So secondary amenorrhea is most likely because of hormones and endocrine, I would say. So you need to think act locally also. Then hormone panel, then UPT. UPT is something which you should do. Then thyroid and endocrinal problems is something which you check. Then you did a UPT and thyroid and normal. Or probably I will also ask you to do an FSH and LH. See, in the primary healthcare, you don't have access to anything. Start her on progesterone. Check whether she bleeds. That means it was something to do with irregular cycles. And it also, see, secondary amenorrhea is something which is also age specific. If a woman of reproductive, adolescent age comes to you, then something to do with HPO axis insufficiency or HPO axis dysregulation. If it's something to do with reproductive age, then proper PCOS or other problems, Asherman syndrome, if she's a case of DNC or something which you should think of. Then if it's something old age and all those things, secondary amenorrhea, yeah, what do you think after menopause? What do you think, it's a secondary amenorrhea or what? Comment that in comment section. Is it physiological or pathological? That's why I say, even in this history examination, if you don't know physiological cause, then it's as good as you have to go back to your first year and have to study. No, I'm serious. If you don't know, then why are you studying in fourth year? Correct. So that is something which is important. So yeah, if LH and LH ratio is constant, that means what? Who produces LH? Hypothalamus, pituitary. So it increases what? Estrogen. Correct. So LH is normal. So if it's constant, and it's most likely PCOS, do an pelvic ultrasound and confirm it whether it's true. Then if she doesn't bleed, that cross pathology, something to do with both estrogen and progesterone. So you start on both. So if she bleeds, that means she had something to do with both hormonal process. So check FSH, LHS ratio. If FSH is more, then estrogen is less. Age is 30-35. Think of POI. If not, if she doesn't bleed, think of blockage locally. That means Asherman. If everything is low FSH, low LH, low estrogen, highest strata approach, do GnRH challenge test, okay, which I have discussed here. Then you will have either normal, abnormal, or exaggerated. Normal means pituitary is normal, right? Then if it's not, that means pituitary is dysfunction. And if it's exaggerated, something to do with hypothalamus. So even treatment part, I will just touch upon here. See, depends from patient to patient. No, this is very, very common. People just say progesterone, OCP, progesterone. Do you want to give progesterone in POI? What is the use? No use, right? Our patient main complaint in POI is infertility in this era than secondary amenorrhea, to be very honest. So there you need to explain, counselor, that no, you have to try with IVF with donor X. So again, for specific things. If it's an adolescent, start on progesterone challenge test. Then also major importance of doing progesterone challenge test. Now let me write. If it's normal also, no. Then even in an adolescent, because this is common, so I want to write it down. That immaturity of axis is something which you need to think. Immaturity of axis. Okay. Immaturity of axis. Yeah, just progesterone will try to balances the cycle and hormones. So secondary amenorrhea is basically what? Hormones. If you know your hormones, if you know the first stata approach, and if you know the endocrino-hormonal workup is something which I would like to comment on secondary amenorrhea. So this POI is, again, you have to do infertility problem. In PCOS, again, she will have a lot of problems. She might have hirsutism. For that, you need to do laser. If she comes about with infertility, then you have to start her on letrozole 2.5 mg. If she has some other problems, obesity, then you need to refer to an endocrinologist for checking out for any other condition like diabetes or metabolic syndrome. If she comes to you with secondary amenorrhea, then again you have to treat properly based on progesterone estrogen combinations. Got it. Then again, if she doesn't bleed, then something to do with, based on this, see, FSLHH and blockage, then you can think of Asherman. If it's just this, and if you have not tested FSH and LH, you don't know anything. Then you have to do GnRH challenge test. Then you know the proper work. So this is very, very, very important, guys. And if you don't know this, you will lose almost 10 to 15% of your patient in your OPD. I mean, I know many might not take gynae, but a primary healthcare physician should know secondary amenorrhea because which is very common. So you need to know to counselor at least. This is our basic approach which I follow. That's it for today. And secondary amenorrhea as a topic and amenorrhea as a topic we have done. So we have almost covered 23.4% according to Shaw's. Someone was asking what is your source. This is the source, Shaw's. You go check the menstrual problem. They said 23.4% is due to in gynae OPD is due to menstrual related problems. In next class we'll discuss something related to menopausal problems. Okay, then we are almost done with your 20 this 23.5 letters for your septic 25. So you have almost completed 25% of your patient complaint. So be happy for that. That's it for today. Tomorrow about menopause. Till then, stay tuned. Bye bye.